Good afternoon, everybody. It's 12:30, and let's begin. Welcome to the CDC's Public Health Grand Rounds. I'm Tanya Popovic, Scientific Director of the Grounds, and I want to welcome those of you who are here and those of you who are watching us externally. About a year and a little bit ago, when we were asked to be creative about doing another series of talks or sessions, it was really hard to be creative and not overdo it. Because it's the first anniversary of our events today, what I would like to do is I would like to share with you, take just a few minutes, some of the people who have been in the background but who are actually very responsible for the grounds being successful and creative. So first of these people is Shane Joyner, who is the communications manager for the entire rounds and who works with his colleagues on internal and external communications and outreach, and among other things is placing us on Facebooks, Twitters, and as of a couple of weeks ago we are on YouTube. So already hundreds of people have watched CDC Grand Rounds on YouTube. The reasons are not just for popularity but also for the quality of systems that allow these huge transmissions of information to be viewed externally. Here is a group of people. Those are most creative people that we have who are responsible for the colors, layout, and everything else. And one of them is this young man, Paul Lee, who is the one who really does most of the design and is responsible for what you see on the screens. A group of writers and editors and people who do the printing of all the materials. Now, when we get here, those of you sitting up front wouldn't even get a glass of water if it weren't for Ronald Lawrence and his colleagues, because he's the one who makes sure that everything here functions and we can enjoy our time. John Iskender leads the group of people who work on science clips and coordinate information that comes on a weekly basis with the information that comes in the Grand Rounds. And here is a number of subject matter experts who have worked on that for the past year with him. We are eligible, as you know, for continuing education credits, and to do that, there is also a group of people who have to make sure that we do this according to certain guidance and rules. Also extremely grateful to our colleagues from the MMWR for publishing our analytical essays following each one of these sessions. 3 published so far, another one in press. The person whose phone and BlackBerry rings most on Thursdays is Neelam Gia, my assistant. And this is how she looks every third Thursday at the end of the day. Now, people who are most to be congratulated for whatever we do are, of course, our speakers and subject matter experts. And we have decided that we need to award the award for most attention-grabbing sessions, and those are 2. We have had almost 100,000 people watching our sessions for the past year, and the top session in terms of viewers was childhood obesity and epidemic, followed very closely by our chlamydia prevention colleagues. So we do want to congratulate them on that success, and we are hoping that the really spectacular team here is going to beat that record. All this is done because of you, our audience, internally and externally. And so we really wanted to know how satisfied you are. We have received comments from different venues, and about 90 to 95% is really positive, or even more than positive, thrilling. And so we deserve some pat on the back. What people like is the perspectives that the session give. They like their timeliness. They like the focus on frontline science and implementation in practice. I do have to give a little bit of credit to Dr. Frieden for this science edge and implementation in practice, because it's always the same question: where is the evidence driving it? Where is the data? And why are we doing what we're doing based on what? So Dr. Frieden gets some credit too. Now, what is it that the speakers think is important for them? Why do they do it? Is it just the marching orders, or do they actually feel there is some benefit for them? This is from Sammy Gottlieb, who was, one of the really most wonderful people to work with. And what she said is she loved them because it makes you think why you're doing what you're doing, what is the impact, and what are the next steps. So she described it as short-term pain for a long-term gain, and I take that as a compliment. Now, there are people who had some suggestions, and there are people who found it very challenging to get up at 4 or 5 in the morning and be with us. So we have heard you, and as you see, we're here at 12:30, not at 9 o'clock in the morning, even though I'm happy to report there was a whole bunch of people here at 9. So we have already trained people to come here at 9. Unfortunately, not everybody is as passionate, and some people don't share my and other people's opinions that this is really the hottest things out of Broadway. But they did have some very specific and good suggestions. They felt that in some instances the format is a bit too rigid and presentation too scripted. True. So we heard them too. And so we are having a topic that is extremely difficult to be scripted because there is 1,200 papers published in the last 16 months since the first case of H1N1 was described, and it's very hard to script. The other thing that is very hard was to script some of the people sitting here, and one of those persons is Steve Red, who I think has like two other brothers that look like him because he is in many places at the same time, and who just told me, you know about those notes and scripts that we worked on? I'm not quite sure I can follow them. I said, perfect timing. The other one is Michael Shaw, really an outstanding laboratorian who can speak in a very engaging way, and you will see that in a few minutes. We're also giving you somebody who can hold the entire city of Chicago when it comes to public health and safety, and also has time for personal life. And so does Vince Cavello, one of the most renowned speakers on risk communication, who has written 25 books on the topic, and who is going to be joining us remotely. So we are taking a risk in trying to see how we can engage speakers who are not physically present with us. But I think you will enjoy a 100% epidemiologist, those of you who are epidemiologists or not, a person who can be an epidemiologist during the day, but when the night comes, that person turns into a sleek and charming TV personality. So with that, we're going to ask Dr. Frieden to say a few words, and we're going to move on with the program. Thank you. We have extended this session for 15 minutes to allow a few comments that I made about people to whom we are grateful, and to allow a little bit more time for the discussion.
Thank you very much, Tanya, and thank you for your leadership of this terrific event, and for all of those who have participated for the progress in the past year, and happy anniversary. The basic concept here is the best available science to the best, highest impact practice. And with H1N1, there was so much that was done, so much rigorous science, and yet, as with influenza generally, so much still to learn, and so much that's so important that we need to learn. So I'm very much looking forward to today's session, and it is more than just coincidence that it correlates with the beginning of at least flu vaccination season, if not flu season, with more than 60 million doses out there to be given, and the first year where CDC is recommending vaccination for everyone over the age of 6 months. So I encourage everyone to get a flu vaccine right after these rounds, or any time after that. And I am a little concerned because it's always a little nerve-wracking to follow Tanya in this format, and when she talks about changing the format and making it more flexible and being kind of like Broadway, I'm a little worried about what the next year will hold, but I'm very excited to learn as well. So have a great session.
Thanks, Dr. Frieden.
Slideshow. Where's the slideshow? Yeah.
There we go. Hi, I'm Steve Redd. I'm the director of the Influenza Coordination Unit and was the incident commander here at CDC during the H1N1 response. And it is really a great pleasure to be here to talk to you about this pandemic, the first pandemic since 1968, over 40 years ago. What I'm going to do in the next couple of minutes is talk about some of the myths and misconceptions that have crept into the H1N1 narrative and try to correct those. The first is that this was a mild pandemic and was of little consequence. And just to flip back to give you a quick review, the first case was identified on April 15th, just about 17 months ago. The estimated number of cases in the United States is in the neighborhood of 60 million. And that includes 12,500 deaths. Most of these deaths, about 90% of them, occurred in people under 65. The reverse of the seasonal pattern of mortality. And 190 countries have reported cases of H1N1 influenza. And in fact, probably all countries have had cases, even if they haven't identified or reported those cases. Turning back to the United States, at the peak of transmission in late October, over 49 states actually reported widespread transmission. The duration of the season was longer than previous seasons. This is the number of consecutive weeks that where more than 10% of the laboratory specimens were positive for influenza. And as I said, 12,500 estimated deaths occurred. You can see on this slide that at the peak of transmission in late October, there was a 5-week period when over 1,000 deaths are estimated to have occurred. In our system that is used to receive reports of pediatric deaths, a much larger number of deaths was reported as well, 344 compared to the numbers that you see on this slide. This is the largest number of deaths by far since the system was established in the 03-04 influenza season. The second myth I'd like to talk about is that because we prepared for a more severe pandemic, we weren't ready for the H1N1 pandemic. And it's true that a number of our planning assumptions weren't correct. We assumed that there would be a case mortality ratio of 2%, that 2 out of every 100 people who got this new pandemic would die, when in fact 2 of 10,000 died. We also assumed that we would detect the first case outside the United States, when in fact the first case was identified from San Diego County. And we assumed that there would be universal susceptibility to this new pandemic virus, when we learned fairly early in the course of the pandemic that the elderly had some immunity, and that was borne out by the epidemiology. And all of this led to an assumption that we would have time to characterize the severity and virulence of this disease before it arrived in the United States, and that we'd be able to make decisions with that information. And in fact, we ended up, and we had to make a lot of decisions early on without all that information. Now, the planning and exercising and training that we did before the pandemic allowed us to know what the decisions were that we were going to have to make, and I think allowed us to be flexible to actually have the kind of response that we did. This is the third myth. I'm actually going to return to this at the end of this session. The myth is that because we've had the H1N1 experience, we're ready for anything and we don't need to do anything else. With that brief introduction, let me introduce the rest of the speakers. Dr. Michael Shaw will talk about the laboratory work that was done that was really the foundation of the response. Dan Jernigan will talk about the epidemiology and particularly some of the new work that was done. Dr. Julie Morita will talk about the Chicago experience, especially the immunization program that was implemented. And Dr. Vince Cavella will review the risk communications successes and the challenges that are out there. Michael.
Thanks, Steve. Good afternoon, everyone. I'm Michael Shaw. I'm Associate Director for Laboratory Science in the Influenza Division of National Centers for Immunization and Respiratory Diseases. And during the response, I had primary responsibility for the overall laboratory activities at CDC. There were 3 clear activities that primarily occupied us during the actual response. Obviously, detection of the virus was important from the very beginning, but also we were very much involved with the selection of a vaccine strain. And one of the ongoing things was continual monitoring, and that's something that actually will not stop. But first, I want to go into what was involved in the actual detection of the virus at the very beginning. This is just a sort of refresher memory on the very first couple of weeks of the pandemic when we first realized something unusual was going on. The first case was a 10-year-old boy that was identified in our laboratory on April 15th as from a specimen that came to us as part of a CDC-sponsored clinical trial of a point-of-care diagnostic device. The protocol, of course, had anything that came up as unsubtypable to be sent to us for confirmation. So that's how we got it. We realized very quickly it was something unusual. What was got our attention was that a second case rapidly followed, a 9-year-old girl, also from California. This was identified on April 17th as part of the border surveillance that was going on in California. Quick analysis determined that it was essentially the same virus that had infected both of those. In quick order, we saw that there was also a genetic match with cases that were popping up in Texas and in Mexico, so it was very clear that something unusual was going on. We had, of course, reports that the Mexico cases appeared to have a more severe disease, but that further investigation revealed that wasn't the case. But a little later, December 2009, the journal Science declared the novel H1N1 influenza virus as virus of the year and lauded the scientists for the rapid characterization and distribution of tests to detect it, as well as for nearly real-time sharing of information. I'd like to emphasize that a large part of that information that was shared very quickly and freely was generated by scientists here at CDC. And it was by releasing that information that it allowed laboratories all over the world to quickly ramp up their response to this virus. This is a picture just giving a couple of people working on the response, but also on the right it sort of shows you just a pile of boxes from shipments that we got several times a day during this response. It was a nonstop effort, 24/7, and as anybody who's run a laboratory can sympathize, every one of those boxes represented a case that the sender considered urgent, so they wanted their results right away. So we were the first ones in the world to identify the virus, and for a while we were the only ones able to do the laboratory test to diagnose it. This is a figure I think probably you've seen many times in one variation or another. It shows the genetic composition of the virus, which illustrates the unique origin, which showed that it was a combination of genes from avian, human, and swine influenza viruses. This particular aspect of it we had determined within a matter of hours, actually, of the virus's arrival at CDC. But what was significant was that this particular combination had never been seen before, either in humans or in animals. We also knew from further extensive analysis of the genetic composition that the hemagglutinin gene, the HA, was a direct descendant of the same molecule that had been found in the 1918 pandemic strain. At the same time it had infected humans, it also went into the swine population, and they were evolving separately along different lineages. So after 90 years had passed, it had essentially become different enough that the human host recognized it as a novel strain, and that's what allowed it to become a pandemic. There are several different aspects of the planning and preparedness that the laboratory was involved in. I won't go into each of these on this list, but there are two in particular that really paid off for this particular effort. One was our ongoing research to develop new diagnostic tests. This was necessary to improve virologic surveillance, and we needed to have these tests in place so we could get them out very quickly. So before going into that, I would like to first concentrate on development of the vaccine, because that was one of the activities that occupied a great deal of very frenzied activity right at the very beginning. When selecting an influenza vaccine, the challenge is always to find a strain that's representative of what's circulating. In the case of seasonal viruses, this involves months and months of just watching what's going on. In the case of this new pandemic strain, it went a little more quickly because the virus wasn't varying that much. It was fairly new to the human population. There wasn't a lot of pressure on it. But we were able to quickly identify a strain that we agreed would be a good one in consultation with WHO and FDA. That was sent to the New York Medical College at Valhalla, who generated a high-yield reassortant, and that's what was actually distributed to the manufacturers. One of the other important things I'd like to emphasize is that this is the same basic procedure that's used every year for the generation of the seasonal influenza vaccine, and it's consistently produced safe vaccine for decades and decades. The final strain decided on was one of the first ones we had gotten from the California outbreaks, California 7, 2009. And on May 23rd, that vaccine candidate was sent to the manufacturers, and the manufacturers essentially took over the production and distribution of the virus. Now, while all of this was going on, we were also continuing to monitor the pandemic virus, and this is one thing we will continue to do, because we always have to do that with influenza viruses, because they're so prone to change. This involves, in particular, tracking it to see how it's spreading, and also to monitor the viruses so we get an idea if there are any changes in it as it is spreading in the population. Now, as I mentioned, we had a PCR test in place at the very beginning for detecting swine-like influenza viruses, and that was what allowed us to identify it so quickly. But it's one thing to have a laboratory in place for research purposes, and it's quite another to have one that can be used for actual diagnostic purposes in a clinical lab. So what you need to do in a situation like that is get FDA approval for use in diagnostic tests. That we got with an emergency use authorization on April 28th, which is very, very impressive, because that's basically just 2 weeks, less than 2 weeks after we initially identified the virus. We were able to roll out these tests, and we distributed them worldwide. Basically, this PCR test allows a laboratory to tell that there is the pandemic strain in the sample that they've gotten. We also, at the same time, distributed HI tests. That's for hemagglutination inhibition. That sort of assay it tells you a little different sort of information if the virus is changing in the way it reacts to antibody as it's circulating. So that sort of leads into some of the genetic properties that we're continually monitoring for these viruses. We're especially interested in changes in transmissibility and virulence, because that can affect the severity of the cases, the number of people infected, and how easily people are infected. We also need to know about the antiviral susceptibility. From the very beginning, the sequence told us that these viruses were resistant to one entire class of antiviral agent, the adamantanes. That made it even more important for us to continue to monitor for resistance to the only remaining class, the neuraminidase inhibitors, like oseltamivir or Tamiflu. So we've been doing that regularly. And also, it's, as with seasonal influenza viruses, we have to continually monitor to see if it's changing in the way it reacts to antibodies, because that can require a change in the vaccine strain potentially. Down at the molecular level, there are a couple of things we are especially alert for changes in. This diagram shows a couple of amino acids up at the very tip of the HA molecule. Because of their location, they're very much involved in the reactivity of neutralizing antibody. A change in one of those or an amino acid nearby around it could cause a drastic change in the way the virus reacts to antibody and could cause us to need a new vaccine strain. Another part we look at very closely is the receptor binding site. This is a pocket on the molecule where it actually attaches to the cell it's going to infect. If you have a change in amino acids there, it could possibly change the location in the body where the virus replicates. It could get deeper in the lungs, causing more severe infection. It could replicate to higher levels in the nose, making more virus produced, making it spread more easily. So that is another part we have to watch very closely. So what have we seen so far from the monitoring we've been doing? Basically, when we've seen changes, there hasn't been any sustained transmission of them. This indicates that right now there's not any selective advantage for them. We've seen no increase in transmissibility or in virulence. When we have seen markers that we associated with virulence in avian viruses, for example, they appear either to have no effect or just don't have the same effect in this particular genetic background. Monitoring for antiviral resistance, more than 99% of the viruses we've tested remain sensitive to oseltamivir, so that remains a good treatment. And also, because the virus is varying very little, the vaccine strain that was chosen is still a very good match. Overall, we can say that in general, the virus is varying, if anything, a little less than the seasonal vaccine strain, seasonal influenza viruses do. So we learned several things from this. Three particular things that are worth emphasis is that the basic laboratory science was what allowed us to rapidly ramp up our activities, to get this information gathered and disseminated quickly, and also to rapidly deploy these tests that laboratories needed to respond to the pandemic. And of course, this feeds into the general idea that preparedness pays off. And this is not just in having the test there, but it's also having trained people and the staff and facilities are incredibly important. And as you saw, for rapid approval of the diagnostic tests, partnership with other agencies within the government, clinicians, WHO, all of that was incredibly important to how this went so smoothly at the very beginning. So as the virus is continuing to circulate, we can expect it's not going to go away anytime soon, and we fully expect it to start changing as it adapts to the human host. One of the things that's going to happen is as more and more people become immune to the virus, there's going to put a selective pressure on it. It's going to start varying antigenically, and we fully expect to have to reassess the vaccine strain composition as time goes by. Also, since we still only have one class of antiviral drug that's effective on it, we need to continue and expand the testing for resistance to those agents. So next, I'd like to turn it over to Dr. Jernigan.
Thank you very much for the opportunity to speak. I'd like to talk a little bit about, in a very brief period of time, on the epidemiology and surveillance, looking at some existing or old approaches as well as some new approaches. I have 8 minutes, and we're not allowed to point out all the acknowledgments of the people that participated, but we had up to 500 people on the Epi Lab team at one point, and we are extremely grateful in the Influenza Division for the support that other folks provided to us throughout, and those numbers of people that stayed with us from beginning to end. I have a couple of things that I'd like to have as objectives. I'd want to point out the characteristics of the H1N1 pandemic in the United States using surveillance systems as a prompt, as well as talk about new surveillance systems and some new methods for evaluation of the H1N1 pandemic. With the identification of those first two cases, like Mike had mentioned in Mexico, and then with the subsequent linkage with slightly different appearing cases from Mexico, a lot of efforts began to try and rapidly characterize the emerging H1N1 pandemic. There were early field investigations where there were case contact studies and community surveys, which helped define the transmissibility of the virus and also the clinical severity of the cases. And this was extremely important for helping to determine those policies about interventions and for who should get vaccinated. These are photos of some EIS officers and staff that were deployed to Chicago that worked with Julie to help define these things, secondary attack rates and other things very quickly that were extremely important early on. At the same time, we enhanced our existing surveillance systems and we also developed some new surveillance systems. And so let me talk a little bit about those systems. Throughout the pandemic, we tracked it with between 8 and 10 different surveillance systems. 4 in particular I'm going to mention here, and those tracked clinics and emergency department visits, they tracked hospitalizations, and they tracked deaths to try and get together a full picture of what the impact that was happening with the pandemic as it was going along. This is a graph of influenza-like illness visits to outpatient settings and emergency doctors, about 4,800 participants in the influenza-like illness network that CDC supports. And inside the red box, you can see the period from the initiation of the 2009 H1N1. That little blip off to the left of the side of the box is the spring wave, notably those cases in New York City. And then you can see the rapid increase in the numbers of cases and the percent of ILI, and a very high peak there in the middle of that box, which really demonstrates an influenza season that occurred about 2 months prior to a normal influenza season happening. And that is directly attributable or directly correlated with the return to school of kids, of school-aged children. But as you can see through the summer, there was still a lot of disease that was occurring in that period between the spring and the fall peaks. And let me give a couple of personal experiences with that. This picture here was a picture of 2 pictures that came in the mail 2 months after my son had gone to camp in North Georgia. And so Timmy is in there somewhere along with 2 other friends of his with 25 campers in his cabin. We paid for both weeks. We got 2 pictures, and so during the first week, however, I got contacted on Thursday along with the parents of 2 of those other kids to come pick up our kids because they had influenza-like illness, which subsequently was found to be H1N1 flu. But it during that time, a lot of kids got sick. And so the second week picture, you'll note, had only 11 campers. And so this demonstrates a greater than 50% attack rate, but it also shows that these are kids that are in close quarters. It also shows that this is what happens when you have no pre-existing immunity and you have influenza circulating among those that influenza likes the most, and that is school-aged children. It also says something about the hygiene of these kids, and it suggests that the title that we changed from swine flu to 2009 H1N1, maybe we could go back to swine flu just for this subset of people. Moving on to our hospitalization surveillance, this is the Emerging Infections Program, 10 sites, 21.3 million people under surveillance, looking at different age groups and the rates of hospitalization. Off to the right, you can see the greater than 65-year-old rates of hospitalization, the red being the pandemic H1N1 rates for 2009. You can see that they are lower than the 2007-2008 H3N2 season, where we normally see a very high rate of hospitalizations among those that are older. If you look at those that are younger than age 65, the red bars are all higher than the previous seasons, indicating that there essentially was a disproportionate or a different rate of hospitalization for those younger than age 65. This really underscores a fact that we found from serologic studies showing that those that were older tended to have some cross-protective immunity to the pandemic H1N1, and those younger than 65 did not, and that's manifested in hospitalizations and deaths. As mentioned previously, this demonstrates our laboratory-confirmed influenza deaths among individuals under 18 years of age, so reportable illness in the United States, comparing it to the past two seasonal influenza seasons. You can see in the square that there were 4 to 5 times more deaths during the H1N1 season, the 2009 pandemic season, than previously, really indicating that there was a lot of activity among kids and subsequent outcomes among those children. So let me talk a little bit about some new surveillance systems or approaches and some methods, epidemiologic methods that were used to evaluate the H1N1 pandemic. First, there were a lot of partnerships with schools and colleges to monitor school dismissal and college illness with the American College Health Association. We also worked with emergency departments and used electronic data from those sources to monitor influenza-like illness, and intensive care units to monitor disease there with networks of clinicians. We also did phone surveys to look at influenza-like illness in the community and also vaccine coverage using the behavioral risk factor surveillance system. We also looked at laboratory-confirmed novel influenza case reports and expanded population-based hospitalization surveillance. There were also, accompanying those new activities, new epidemiologic methods. There were ways of looking at estimates of excess deaths in comparison to past influenza seasons and to past pandemics to try and get a sense of where the severity of this particular pandemic was hitting. We also developed ways to have new ways of visualizations and showing geographic spread using influenza-like illness information. And then also we developed new frameworks for assessing severity and impact of emerging influenza viruses that we're working on with WHO right now. And a pyramid model was developed for estimating flu disease burden, which was a collaboration of outside modelers, inside modelers, and other researchers. This is the outcome of that estimation method, indicating that there were 61 million cases between the period of April 2009 to April 2010. There are 274,000 estimated hospitalizations and 12,500 or so estimated deaths. This again just pointing out that the rate of cases was very high among those that had no pre-existing immunity in the school-aged population, but the rates of hospitalizations and deaths were lower than would be expected for those that were older. And so again pointing out the difference in epidemiology by age during the 2009 pandemic. Let me finish by pointing out a couple of observations of epidemiology and surveillance in action. First, the existing surveillance systems, a surveillance base, was in place, and that allowed for us to have a rapid surge. We had prior years of surveillance information that provided a baseline so that we knew when things were different, and we were able to easily ramp up from that. There were multiple surveillance systems that we monitored for changes in character of the pandemic or of the virus, and we were able to rapidly translate the data into decision-making two ways. The early case contact and community investigations helped define risk groups and directed vaccine policies and interventions very early. And then the ongoing assessment with surveillance systems provided us a picture of severity that helped us tailor prevention and control activities and recommendations. And with that, let me hand this over to Julie.
Thank you for this opportunity. Today, what I wanted to do was to summarize the Chicago response to the H1N1 pandemic. Chicago is the third largest city in the United States. Our population is 2.8 million. In Chicago, the first pandemic H1N1 cases were confirmed on April 28, 2009, by the Illinois Department of Public Health Laboratory. By May 15, 2010, the number of H1N1 associated hospitalizations reported was 955, and the number of deaths reported was 30. Chicago's allocation of H1N1 vaccine was based on our population. By May 2010, the number of doses available was nearly 1.3 million, and the number of doses distributed was more than 1.1 million. There was an overwhelming need for bidirectional communication with the partners displayed on this slide. A small team worked around the clock to collect information about cases, engage federal and state partners to obtain information about the virulence and transmissibility of the virus, provide frequent updates to the mayor's office, local legislators, and public safety officials, and to provide guidance to the local workplaces, schools, healthcare providers, and the general public. The communication continued throughout the pandemic. The governor of Illinois, the mayor of Chicago, state and city health officials, and school officials worked together to provide updates on disease activity and prevention measures, including school closures. Our pre-pandemic surveillance system consisted of outpatient reporting of ILI and case-based reporting of pediatric deaths. We quickly expanded that to include laboratory surveillance, emergency department ILI, surveillance, and case-based reporting of all hospitalizations. Non-pharmaceutical community mitigation guidances were developed and distributed for schools and daycares, workplaces, and social gatherings. They addressed exclusion from work, school closures, and the use of masks in public settings. Communication activities were geared toward the general public as well as the healthcare community. The rest of my talk will focus on our vaccination planning and the implementation as an example of our strategy and partnerships that we guided our city-level response. This summary of hospitalizations associated with the H1N1 pandemic in Chicago provides a reference point for when our vaccination planning began. By the beginning of June, when H1N1 activity was peaking in Chicago and winding down in other parts of the nation, we were charged with distributing all of the H1N1 vaccine in Chicago, and CDC quickly established conference calls weekly to guide our vaccination planning efforts. By the middle of June, our planning efforts began full force. Chicago's vaccination plan was conceived by the immunization program and then reviewed by many stakeholder groups, including an infection control advisory group, our City Board of Health, state health department staff, as well as CDC staff. We formed special teams to lead both aspects of our two-pronged approach. The first prong including distributing vaccine to healthcare facilities for their healthcare personnel as well as for their patients. And the second prong including conducting large-scale mass vaccination clinics for those without healthcare providers and for those whose healthcare providers did not order vaccine. This timeline depicts how rapidly we developed and implemented our distribution plan. By the end of June, we had engaged healthcare providers through a series of conference calls, electronic newsletters, and broadcast faxes from the Vaccines for Children program, professional organizations, hospitals, and long-term care facilities. On August 5th, CDPH's web-based pre-registration system open to determine the number and type of providers who were interested in administering vaccine. 1 month later, our web-based registration system opened for providers to provide an electronic signature for the memorandum of understanding, the number of doses of each formulation they desired, and the delivery information. On September 30th, we were notified by CDC that 21,000 doses of the live attenuated vaccine were available for Chicago. The distribution team submitted orders for all available doses on that day, and they were delivered to the Chicago Fire Department for emergency medical services staff and to Chicago hospitals for their healthcare workers. The vaccine all arrived 5 days later. When we received the guidance or projections for vaccine supply that were much lower than anticipated, we established guiding principles for vaccine distribution. For example, we decided to distribute to facilities based on their patient population, and we prioritized the ACIP priority groups. We also decided to distribute the entire allocation that we received the day that we received it when it was available. Using an electronic registration system and email communication, we registered 764 healthcare facilities to receive the H1N1 vaccine. Pediatric providers, including family practitioners, represented the highest proportion of facility types. CDPH's mass vaccination clinics were housed in the city colleges of Chicago, selected because they're large facilities geographically distributed throughout the city, accessible to those with disabilities, and because CDPH routinely uses these sites for our large-scale seasonal influenza clinics. Our clinics ran from October 24th through December 19th, 3 days a week. In addition to CDPH staff, we used CDC public health advisors and contract nursing staff. Our vaccine distribution sites included healthcare facilities as indicated by the blue dots and CDPH mass vaccination clinics as indicated by the red dots. Healthcare facilities and mass vaccination clinics were distributed throughout the city. Our guiding principles for our mass vaccination clinics included vaccinating those without healthcare providers or whose healthcare providers didn't have vaccine, and promoting clinics for the ACIP target groups. However, we didn't deny services based on residence or target group. We also reserved inactivated vaccine for patients with contraindications to the LAIV. Here you can see the doses administered at each mass vaccination clinic. Over 100,000 doses of vaccine were administered at these clinics. Between 5,900 and 26,000 doses of vaccine were administered at the sites that were open 3 days a week. Putting our mass vaccination efforts into perspective, we distributed the highest percentage of vaccine to pediatric providers and hospitals, while distributing less than 10% of CDPH mass vaccination clinics and to adult providers. Overall, we distributed a higher percentage of vaccine to healthcare facilities than we originally anticipated. Chicago's hospitalizations associated with the pandemic are represented by the light blue bars, our cumulative vaccine allocation by the blue line, and the cumulative vaccine distributed by the red line. The second peak of H1N1 activity in Chicago occurred in early to mid-November, when less than half of Chicago's H1N1 vaccine supply was available. Since demand for the vaccine diminished in late November, the vaccine supply was inadequate when the demand was the greatest. We identified these successes in vaccine distribution. Healthcare facilities played a larger role in vaccine delivery than anticipated. Less than 10% of our vaccine was administered by our CDPH mass vaccination clinics. Our pediatric provider enrollment was higher than other provider types. Our electronic registration allowed for efficient data management, prioritizing healthcare facilities, and tracking vaccine distribution. And our dedicated email and phone line assured high-quality customer service. Challenges we identified included the vaccine supply was inadequate when the demand was the greatest. Adult provider engagement was less efficient than pediatric provider engagement due to a couple reasons. We had minimal public health infrastructure for adult vaccination activities, and our public health relationships were less well established with the adult professional organizations, including ACOG and ACP, when compared to our pediatric professional organizations. Lastly, we were extremely disappointed by the incomplete reporting of the doses administered. Only 51% of the distributed vaccines were reported as being administered. We offered these potential solutions: improve vaccine manufacturing processes to increase production speed, dedicate sustained funding for development of an adult immunization program similar to the childhood immunization program, improve use of immunization information systems, also known as registries, to improve reporting of doses administered. This can be done by increasing recruitment of healthcare facilities and also by developing interfaces between electronic health records and registries. We considered it a success that nearly 100,000 people were vaccinated at our CDPH mass vaccination clinics. The vast majority of the vaccinees were racial and ethnic minorities, and more than half were adults. The public health emergency response funds were essential for us to contract with cold chain management company to manage our mass vaccination supplies. They were also used to cover staffing. Mass vaccination challenges included using a paper-based system for tracking vaccine receipt and administration. As a result, our registration data were not linked with the state immunization registry, and we were unable to establish a reminder recall system for children needing second doses. In addition, staff mobilization was challenging because of labor union and contract procedures, which slowed the process of assigning staff to the mass vaccination clinics. Here are some proposed solutions to improve the function of the mass vaccination clinics. Develop a web-based mass vaccination registration system to interface with our state immunization registry. Establish contracts for services that might be needed during emergencies ahead of time. And engage unions to establish efficient processes to mobilize union staff in emergency situations. In summary, Chicago has a long history of dealing with influenza epidemics. As in many other places, there were signs of panic. However, our partnerships and planning allowed us to respond quickly and appropriately. Thank you. The next speaker will be Vince Cavello.
Hello, everyone. It's a pleasure to be with you today, and I'm very excited to be together with my distinguished colleagues. My name is Vince Cavello. I'm the director of the Center for Risk Communication in New York City. And what I'd like to do today is share with you several thoughts related to H1N1 risk and crisis communication, particularly focus on successes and challenges. I actually have three goals that I have today. The first is to share with you several key concepts from the risk communication literature. That literature actually includes over 8,000 articles and over 2,000 books, so I've selected out several to discuss. The second is to evaluate CDC's pandemic communications against these core concepts, and the third is to identify challenges for the future. The first concept that I've selected for attention is one that is, in many ways, I believe, probably the most challenging. It's that when people are stressed and concerned, as they are during an epidemic or pandemic, they typically want to know that you care before they care what you know. The second concept is that when people are stressed and upset, as during the pandemic, they have great difficulty hearing, understanding, and remembering information. And the third concept is something that perhaps is not as intuitive as the other two, which is that people tend to trust most those willing to acknowledge the importance of uncertainty. If we come back to that first concept, that when people are stressed and upset, they typically want to know that you care before they care what you know. As you can see in this graph, this pie chart, there's a number of factors that contribute to the perception of trust, which is one of the most important perceptions driving people's motivation, actions, behaviors. And among all those factors, which include competence, expertise, honesty, openness, transparency, the research now indicates that the listening, caring, empathy, compassion dimension perception accounts for as much as 50%. And these decisions about care and empathy are often made in as little as 9 to 30 seconds. The recognition of the importance of the caring principle in risk communication, I believe, was well illustrated by Mayor Rudolph Giuliani in 9/11. At the first press conference, nearly 4 hours after the collapse of the World Trade Center, when asked the question, how many people did he think had died, his statement was, the number of casualties will be more than any of us can bear ultimately. He went on to point out that my heart goes out to all of the innocent victims of this horrible, vicious act of terrorism. The importance of caring principle was also reflected in the CDC's pandemic communications. For example, in the spring of 2000, Besser, acting director of CDC at the time, I'll quote him as follows. First, I want to recognize that people are concerned about this situation. We hear from the public and from others about their concern, and we are worried as well. The importance of this carrying principle is reflected in the risk mitigation literature through a number of what are called templates. Templates are tools derived from the risk mitigation literature. Examples of templates include, and I've included two here. First is something referred to as the CCO template, meaning that the first message in response to a highly emotionally charged question should be a message of compassion. The second C stands for a message of conviction, something that you believe in firmly, and the third letter, the O, stands for optimism. Another key template that derives from the carrying principle is called the CAP template, which means that we begin with a statement of compassion, move on to a statement that indicates what actions we're taking, and finally we try to put the issue in perspective. The second key concept that I'd like to share is that when people are stressed and upset, as they are in an epidemic, pandemic, any threat to public health, they have difficulty hearing, understanding, and remembering information. This particular principle can be translated into something practical, something as practical as what is often referred to as the KISS principle. Sometimes KISS is defined as keep it simple and stupid, keep it simple for stupid people, but I reject that. People are often very intelligent in responding to information, and I prefer to say keep it simple and short. There are several templates that derive from the KISS principle, keep it simple and short, such as the Rule of Three template, which indicates that we should limit ourselves on average to no more than 3 key messages in response to any question or concern. The 2793 principle, which actually goes further, it not only specifies 3 key messages at the core of any response, but also try to keep it very short to no more than 27 words, 9 seconds, 3 messages. And finally, another template that derives from this literature is called the primacy recency template, which indicates that when you do offer up 3 messages, that is to your advantage, holding constant other variables to put the most important message first, as the primacy dimension, and the second most important message last, which is the recency dimension. This notion of everything in threes, 27 words, 9 seconds, 3 messages, which can be expanded to repeating the message 3 times, providing 3 supporting facts or credible sources for each message, is very well reflected in a device, a technique used by risk communicators called a message map. A message map begins with a stakeholder identification, a stakeholder question or concern, and then several top-line or key messages that would be reflected in approximately 9 words on average for each of the key messages that you can see in this graphic. CDC made extensive use of the message mapping process throughout the pandemic. In fact, as early as 2006, that 65 pandemic message maps were produced by various work groups, and they were published on the CDC's website, Department of Health and Human Services. You can actually still find those 65 message maps on pandemicflu.gov just by calling up message maps. The message maps' top topics included a wide range of issues of concern to the public. They included everything from preparedness to antiviral medications to issues such as human-to-human transmission. And because message maps change, this is an ongoing CDC activity as more information becomes available through both science as well as policy. For those interested in message mapping, I provided in the next slide 2 references where you could read more about this technology and the theories from which they derive. The first is called Risk Communication and Message Mapping, a new tool for public communication. And the second is a World Health Organization document called Effective Media Communication in Public Health Emergencies. The third concept I'd like to share is that when people are stressed and upset, such as during a pandemic, they tend to trust most those willing to acknowledge the importance of uncertainty. I mentioned before that this is one that is least intuitive. It's one that typically individuals will avoid because of perceptions that they may be perceived as less than competent. And yet the research indicates exactly the opposite, that the willingness to acknowledge uncertainty enhances trust and credibility. I believe that the importance of this principle is reflected very well by Dr. Besser in the early stages of the pandemic when he stated as follows, I want to acknowledge the importance of early stages of an outbreak, there's much uncertainty, probably much more than anyone would like. Our guidelines and our advice are likely to be in term and fluid, subject to change as we learn more. Quite a strong statement of uncertainty that preambled the CDC risk communications. Dr. Frieden also reflected the importance of acknowledging uncertainty when he remarked in September of 2009 that the opening of the vaccination campaign for H1N1 is, in quotes, going to be a little bumpy. I should mention that related to the notion of uncertainty, that there's challenges, and particularly I would focus on challenges related to the sharing of numbers. That one of the key principles that come from the uncertainty literature is that messages about numbers or estimates need to be bracketed with statements of uncertainty. This, unfortunately, was not done, I believe, as well as it could have been done at the very early stages of the availability of vaccination, starting in August, and this came home very much in October when we didn't have as many vaccines available as we had shared with the public. Certainly, the BP oil spill has illustrated the importance of bracketing numbers with uncertainty. In April of 2010, the world was told there were 5,000 barrels a day coming from the oil spill, and yet in June we were informed that it was 60,000 barrels a day. This tends to undermine trust and credibility. Dr. Peter Salmon, one of the leading experts in risk communication in the world, emphasized the importance of for a pandemic of uncertainty in the following quote: "Nothing is more important in pandemic risk communication than persuading the public and the politicians to think probabilistically, that public health officials need to insist on their uncertainty, and they need to make uncertainty the message, not the preamble to the message." The importance of uncertainty, as well as these other principles, was incorporated in the trainings offered by CDC at all levels, local, state, federal. These training programs were spearheaded by Dr. Barbara Reynolds with an incredible support team and others at CDC, including Dr. Marsha Vanderford and Donna Garland. That program had, I believe, an incredible effect on the quality of the communications that were coming out. Finally, I'd like to finish up with three challenges where I think that there's room for improvement. Three challenges are, first, to address the challenges associated with cultural diversity. The second, the challenges associated with message timeliness. And the third, the challenges associated with social media. If we take cultural diversity first, it's well known that we must target our audiences, and yet this is probably one of the most difficult things to do, that audiences are very different in their values, very different in terms of the messages they will accept, very different in terms of the sources of information they rely on. If you look at the next slide, which is an incredibly complex slide that deals with Hispanic risk communication, we start off on the left-hand side with a wide range of variables that affect public perceptions. There's over 20 of these perceptual factors now, ranging from trust to voluntariness. But these factors get filtered through a prism of culture. For example, in Hispanic communities, the family is a very important part of that culture, and therefore messages that appeal to the family are likely to be more effective. And then in turn, it has to pass through another filter, and that is what we know about health beliefs. And finally, it comes out at the end in terms of our messages, the messengers, and the means we share. Finally, the second challenge is message timeliness. And message timeliness, when I started in this field nearly 30 years ago, we used to feel the luxury of what's called the 24-hour news cycle. We had 24 hours by which to respond to an issue, to share messages. Unfortunately, by 2001, when 9/11 happened, that 24 hours had shrunk down to 4 hours necessary to respond, where the airwaves were already being filled with credible sources of information and messages. And finally, in 2010, with the BP oil spill, that 4 hours had been reduced down to 4 minutes. It becomes effectively the 4-minute mile to get our messages across, because others will be sharing messages. Certainly when CDC has a motto such as "Be First," it's very hard to be first when you only have 4 minutes to go through clearance and all the types of activities associated with messaging. And finally, I just wanted to point out the challenge associated with social media. This is certainly a new technology. People are now sharing information. They're talking to each other through Facebook, through Twitter, through blogs, and we're still grappling with how to deal with the social media, especially given issues such as security and privacy. I'd like to finish up with just two quotes that I believe reflect very much the approach that a risk mitigator takes. The first is from our former president, President Abraham Lincoln, when he said, "If I had all day to cut down a large tree, I would spend most of the day sharpening my axe." And finally, from Mark Twain, who said, "It takes me on average 2 weeks to prepare an impromptu speech." I'll now turn it back to Tanya.
I think there's, maybe to summarize this, we have to beware of complacency or overconfidence following the response. There are a number of areas that we need to continue to work on. Vaccine development and availability are key among those. We'll need to continue to work to enhance surveillance to collect viruses so we can start that development process that Michael talked about. There has recently been a big investment in improving the technology to produce vaccine. And we also need to learn from the experience that we've had in the H1N1 epidemic to optimize our delivery strategies from the standpoint of achieving high coverage at cost and also preventing disease. From the planning, exercise, training standpoint, we need to continue to work here as well. We have a full calendar of exercises planned for the coming year, culminating in a 3-day exercise in March. And while we've talked about H1N1 today, a year and a half ago, H5N1 was the thing that we were most concerned about, and it's important to remember that it's still out there. In fact, during 2009, there were more cases of H5N1 than there were during 2008, and cases are still being reported with a case fatality rate in humans of around 60%. So just to wrap up, the H1N1 pandemic had a substantial health impact. You've heard repeatedly how preparedness helped us respond, but we still have more work to do to be prepared. So thank you very much. We have about 15 minutes for questions, and let me open the floor for questions. Harold.
I'm curious to learn more about lessons learned. Specifically, what did we learn about the importance of closing and then reopening places like schools and camps? What did we learn about the use of Tamiflu for family members? How can we apply what we learned to the next time?
Well, a lot of these lessons are still being captured from the scientific standpoint, and I would say that in both of those instances, what we ended up doing was not what we initially had planned to do for that more severe pandemic. I will say, without divulging anything that's not yet published, that there are several experiences of examining the impact of school closure, short-term school closure, on disease transmission. From the standpoint of the use of antiviral drugs to prevent transmission, this was not something that we recommended in the United States. In the UK, I think we will have some experience to reflect on. And I think this really raises a question of the science that forms the basis for our response, but the need to adapt that science base to the situation that is occurring. And something that we work very hard on, especially early in the response, but really throughout the response.
If this is Vincent Covello, if I could say something about this issue, is that possible?
Yes.
In addition to what we just heard, that I believe the school closing issue points to another key concept in risk mitigation, and that's the importance of coordination and shared responsibilities. And I believe the controversies associated with school closing illustrate the importance of working together with others to work out policies in advance and to make sure that we have consistency among those policies. If one school closes but others don't, automatically it starts raising serious questions about trust and credibility. And it really points to the need to partner very closely, especially with the schools, given the importance that we attached to our children, and to work out these policies well in advance based on the best available science.
Thank you. I'd be interested to hear some reflections, perhaps Dan or Julie, on surveillance. Fortunate to have a very strong core of surveillance systems, but you also explored a lot in novel, innovative surveillance approaches. In particular, as we all look forward to electronic health records, you had some explorations of, in pockets, electronic health records, and it didn't seem that we got much out of that. Can you reflect a bit on where you see that going, what the challenges were with that first round of experience?
Sure. I think we had a number of existing surveillance systems, and we, I think, had the promise of a whole lot of the newer approaches to monitoring things through electronic health records or through available electronic data. And so one major lesson is learned is that don't try and build the plane while you're flying it. I think it was an opportunity where a lot of vendors of these products that service electronic health records, or actually are the providers themselves, engaged with us. And what we had was all at once 5 or 6 different formats, different approaches, different purposes for why they had that data. And so if we had had in place the right pipes, I think, for them to plug into, the right standards set up, it would have been a whole lot smoother. We would have also been able to, I think, have a much better understanding of what that data means. It does point out the differences between data that is used for prompt versus data that's used for verifying. And so some of these systems are really good for prompting us to look further, and other systems are absolutely critical for verifying information. And so you can't have just one or the other. You really need to have both things. And so figuring out how to incorporate those kinds of electronic systems into our regular activity here, especially with the way things are moving with electronic health records, health reform, et cetera, is critical. And so we hope to take the information that we have and the lessons that we've learned from that and apply that to a broader context for other illnesses as well.
I think Dan's point about not trying to do it to come up with responses or new systems in the middle of a crisis is really a really important point that we learned, a lesson that we learned. We actually didn't try to implement anything high-tech in the midst of the pandemic, and so what we did is we collected everything very manually. Right now, what we're trying to do since the pandemic, a lot more health systems have reached out to us to say, we have electronic health records, we'd like to work with you to be able to submit information to you, and so now we're working with them, and hopefully we'll be able to use some of our pandemic funds to support their efforts as well.
We have a question from Envision. Sounds like we don't, so from the audience in the auditorium here, John?
Question for Dr. Morita. In terms of the actually many years, technically I suppose many decades of preparedness activities, some at the federal level, some more focused at the state and local level, that led up to the actual pandemic, what, in your view, what aspects of that preparedness and planning were more and less helpful?
And if we talk specifically about the vaccine, our vaccine planning and response, I would say what was most helpful to us wasn't really a preparedness activity, but our VFC program. Without the VFC program, we would have really been lost, because our vaccine ordering system was based on the VFC system. Our vaccine distribution was best to our pediatric providers, and we struggled to reach out to adult providers. So I would say that from our perspective, that VFC program was an essential component, was the foundation of our vaccine distribution system. That was the best. We have over the years done a lot of exercising or using seasonal influenza mass vaccination clinics as exercises, but it wasn't a tabletop. It was actually doing the vaccine administration in these city colleges. So we had years of experience in those settings, and that was incredibly helpful. So I would say that those kinds of exercises, the VFC program, were of the greatest value in terms of the vaccine response.
If I could add something about preparedness for communications, that I know it related to the operational side, but I do want to focus just for a second on the advanced preparation in terms of anticipating questions that CDC did. To go back to look at all previous epidemics and pandemics, see what questions people had asked, and then to work together with both scientists and policymakers and developing answers to those questions in advance of the actual pandemic itself. I think that advanced thinking, anticipating, preparing, practicing was key to the effectiveness of the campaign.
Question.
Is Steve Red. Sanjeev Savkoda, medical epidemiologist working for Countermeasure Response and Administration System, which is CRA, which also tracked almost like 14 million vaccines doses administered in the first 8 weeks of the pandemic influenza until November 21st, one of the system. My question is, Dr. Red, that you very nicely gave a comparison between our planning assumption and what we really had in H1N1. In the planning assumption, we all our resource and effort, we all recognize that the pandemic is going to start not in the United States. And then, as a contrary, we saw, it really started in the United States. What went, what were the limitations that we were not able to envision or not even put in the planning assumption that is going to start for us to at least, prepare?
Yeah, well, I think that the question really is, to plan, you have to have assumptions. And I think the key point is that when the actual event begins, you shouldn't necessarily follow the plan if it doesn't fit. You need to change the plan on the reality rather than on the assumptions. And I think in the parts of the response where we were able to do that, things went better. In places where we didn't do it, they didn't go as well. So I think really the key point is flexibility in implementation.
This is Vincent speaking. Also, I believe that flexibility extended to the communication side too, because the original set of anticipated questions, 65 questions, were focused on H5N1. But then, of course, when it turned out to be H1N1, there was the flexibility to shift to that issue.
Harold?
In the popular media, this was portrayed as a very serious threat. Could you tell us more about what actually happened? And then Dr. Morita alluded a bit to the difficulty in vaccinating pregnant women. But if they really were a priority, could you tell us more about how they could be better accessed for vaccination?
Let me ask Julie, and then I'll come back to more.
We actually saw, I'm not sure, we don't have a good way to assess what kind of penetration we had into our obstetric and gynecology practices. We had several practices that got vaccine directly from us. We also distributed to hospitals who then redistributed it to their practices as well. And what I was impressed with that at our mass vaccination clinics is I went to many or most of them, and we saw hordes and hordes of pregnant women coming to those clinics. So I think the mass vaccination clinics really did serve as that safety net for those people who didn't have health care providers. And we didn't, because we don't really have a good denominator, because we don't have much an adult immunization system to track how well we're doing in terms of distribution. I can't really talk about how well we did, but I do feel like we tried to get our messages out through the professional organizations, ACOG in particular, but our relationships just weren't as well established as they were with our pediatric professional organizations, so we weren't as confident the messages were getting out there.
Yeah, at the national level, this was an important focus. There was a lot of activity that occurred during the response, both to understand the impact and to intervene. Very good collaboration with the American College of Obstetricians and Gynecology. Just roughly, well, I think there's actually kind of a technical issue here too, in that the systems that were put in place didn't have the kind of history that the systems that Dan Jernigan described did. So it was very difficult to compare pre to during the pandemic, but many times more women died and were hospitalized during this pandemic than during normal flu seasons. I'd also say that it was a relative success in terms of the proportion of women who were vaccinated, maybe around double what is a good year in a seasonal campaign. So I think this is actually an important area to continue to build on, since pregnant women are at risk for flu every year. The better that we can do year in and year out, the better we'll do for the next emergency like this.
I could add that I shared a slide dealing with cultural diversity and complexity of dealing with different cultural groups sources, they turn for information, and that if we really want to extend the preparedness to the very highest levels of excellence, that we would have to have the same models for the pregnant woman group as is for any other group.
Yeah, I wanted to follow up on with Julie on the vaccine distribution. You know, at CDC, we stress the need for local decision-making and flexibility and the ability to, allocate vaccine to the places that would be most effective to reach people. But on visiting your city during those mass campaigns, I was struck with the interdependence of the city and state and neighboring counties, and wondered whether, in retrospect, you think there's strategies that CDC could have done differently that would have helped you more, or if there are other things that need to be done before the next response, given flexibility and the need for interdependence.
Well, Anne came to visit in the beginning of December, and it was that weekend that we were actually making a decision on whether or not to broaden our recommendations beyond the initial target groups. And we had dinner with a state health official as well as another county health official from a nearby county, and we had some very heated discussions regarding the importance of broadening, because in Chicago we were ready. We felt like we wanted to broaden. We almost felt like it was too late, that we had waited too long, and the state did not agree necessarily. But we had some very good discussions, and Anne's presence actually helped us to move forward and make that recommendation and have the entire state make the recommendation at about the same time. But I actually think that allowing local flexibility was the right decision, because we would have proceeded even if the state had not. It was a good thing that they joined us. I think it was a better message to have, but I also feel like if they hadn't joined us, we were ready, and we felt like we had, because CDC had said it was could be made at a local level, we felt like we could move forward. So I think that was very helpful to have that ability to make that decision at our level.
This concludes Public Health Grand Rounds September 2010. And I want to thank the speakers very much for the work, and thank you for the audience for the questions and the attention, seen audience and unseen audience. Thank you very much.